Okay, I'm back. Sorry to delay. I'm just going to hang on, I'm going to share my slides again. Share screen and just share my slides. Okay, we'll just. I'll try to finish off. So, yeah, as I was saying about what volume of maintenance fluid that a child should get. Well, like I said, we start with the 4-2-1 rule. That'll often result in overhydration. And in fact, we know that from studies that if you give 100% of a child's maintenance fluid, at least a quarter of children with meningitis will get facial edema, and they have a worse outcome, probably because they also had cerebral edema. So you really should start with half or 2/3 of the maintenance fluid rate that you calculate with 4-2-1 or 150-20. You should always know the total fluid intake of the patient, and that is the combination of IV fluids, nasogastric fluids, oral fluids. And don't forget you add the drug flushes and the diluents as well, because that can add at least, well, it can add up to 50% to the TFI that actually the patient receives. So we just have to be very careful and reassess every day the child's hydration state and yeah, respond if they're overhydrated, if they've got puffy eyes, or if their hands are swollen, or respond if they're underhydrated. I've talked about how to make up IV fluids. I think you add 100 mils of 50% dextrose to 900 mils of Hartmann solution. What you get is a 5% glucose solution. It could be with normal saline or with Hartmann's, but it's better with Hartmann's solution. That's 5%. That's Hartmann's solution plus 5% glucose. I've talked about hyponatremia and how that's really, quite common in pediatrics with the syndrome of inappropriate ADH secretion. There are some children who get hypernatremia though, and that's where children are losing more water than salt, right? So they may be losing salt and water from diarrhea, but they're losing more water than they're actually losing salt. And sometimes that can occur if patients, for example, are given lemonade when they've got gastroenteritis. If they're given a high glucose containing solution, then they'll get what's called an osmotic diarrhea. They'll be losing water because the high glucose load in the gastrointestinal tract draws water out from the gut, so it can cause an osmotic diarrhea. There's a few other conditions that cause hypernatremia as well. I won't go through these, but mostly it's where you've got gastroenteritis with an osmotic diarrhea. You get hypernatremia, and that can cause problems too. Sometimes also with the brain. It's not as common, but it can also cause problems with the brain. Particularly, it can cause strokes, and that's because of hypernatremia leads to sludging or slow blood flow through the brain. This was a child who had a serum sodium of 170 and had a widespread strokes, as you can see. And sometimes it causes venous sinus thrombosis, so the cerebral venous sinuses become very slow flowing and sludgy and thrombose, and that can lead to venous infarction of the brain, which is what this is. Some children with hypernatremic dehydration are often hard to pick, but they often get labeled as if they've got meningitis. They're irritable, they're lethargic. They sometimes have meningeal signs, like they may have ataxia or tremor or hyperreflexia, seizures, reduced Glasgow Coma score. They may be quite poorly conscious or even appear to have meningismus. Their skin feels very doughy. And if you've ever kneaded bread, like baked bread, and you've kneaded it, when you're kneading the dough, that's what their abdomen feels like. So if you ever feel the abdomen of a child with gastroenteritis and dehydration, and their skin feels doughy, just like bread, then you worry that they've got hypernatremic dehydration. It's as I say, it's sometimes quite common that they get diagnosed, or they get labeled as if they've got meningitis, when in fact they've just got hypernatremic dehydration. So in children who've got hypernatremic dehydration, if their sodium is above 150, you should rehydrate them very slowly. And you're aiming for the sodium to fall slowly. So no more than 0.5 millimoles per litre per hour. So their sodium should fall no more than 12 millimoles over 24 hours, for example. If the sodium's 170, then in 24 hours time, it shouldn't be normal. It should be down to 158, but no lower than that. So I just want to touch on how we monitor children on IV fluids. This is really basic and important things that we need to do every day. We should check for edema. I mean, particularly I check all patients to see if they've got puffy eyes and look for lower limb swelling. I always feel their hands and feel if they've got swelling of their hands, feel their lower limbs, their feet, and feel if there's edema. If they've got edema, you should stop or slow the IV fluids. It makes sense, but we don't always do it. Sometimes we just keep the IV fluids going and give some Lasix, furosemide or something. That's not very ideal. We should check for signs of dehydration every day. Those signs I've talked about before: poor capillary return, cold limbs, sunken eyes, poor skin turgor, tachycardia, hypotension, low pulse volume. Remember, when you're feeling the hands, feel whether they're warm or cold, feel the pulses, feel the pulse volume, look at the blood pressure, look at the pulse pressure, the difference between systolic and diastolic pressure. And if dehydration is present, then we should correct the deficit and look for the cause. We should weigh children on IV fluids whenever we can. I mean, if a child gains more than 5% of their body weight over 24 hours, then they're probably getting too much fluid unless they started being dehydrated. So if we can, weigh patients to get a good handle on their rehydration. And we should check their serum electrolytes, if not daily, every second day. And if you find an abnormality like hyponatremia or hypernatremia, then they should have it checked every day. And we should correct their hypo or hypernatremia by adjusting their fluids, either giving them less water if they're hyponatremic, or giving them an isotonic, a balanced salt solution, for example, as the fluid to use, avoiding hypotonic solutions, rehydrating them slowly if they're hypernatremic. We just have to respond to their electrolytes and correct their serum sodium. I wanted to briefly touch on fluid boluses. I will only briefly touch on this, but you probably have heard about the study in Africa that gave fluid boluses to children with severe infection. It was called the FEAST trial, the Fluid Expansion as Supportive Therapy in children with febrile illnesses. And it was a very large study in Uganda and Kenya and Tanzania. It involved over 3,000 children. And these children had a febrile illness, basically. A lot of them had malaria, some of them had meningitis or pneumonia. And they had fever with signs of one or more of prolonged capillary refill or tachycardia or a weak radial pulse or cold extremities. And so they were considered to have shock requiring IV fluid boluses. And I just show you, this is what happened to them. Those children who got a fluid bolus had a much greater risk of dying. And these children received fluid boluses of somewhere between 20 and 40 mils per kilo of fluid. So quite large fluid boluses. It was mostly 20 mils per kilo of fluid, but some got 2 lots of 20 mils per kilo of fluid. And I won't go through the statistics, but basically the mortality rate in those that got a fluid bolus was 10%. And in those that didn't get a fluid bolus, it was 7%. And that was a very significant difference. And it was related to the fluid bolus the children received. So we know that giving a large bolus of fluid like that, 20 mils per kilo of fluid or more, it can be very dangerous to children. This is what's called a Kaplan Meier curve. I won't go through this too much, but this is the hour after admission to hospital or randomization to the study. And this is the probability of death, the cumulative probability of death. And you can see that the children who didn't get the fluid bolus had a much lower risk of death, probability of death. And the children that got either albumin or saline had a higher risk of death. And so what we can conclude from this is that for children who have a severe infection, but don't have dehydration. None of these children had dehydration. They just have a severe infection like pneumonia or malaria or meningitis or unconsciousness or fever, then fluid boluses can be quite dangerous. So we should be very careful about using excessive fluid boluses in children with common febrile illnesses if they don't have shock and they don't have hypovolemia or dehydration. None of these children had hypovolemia or dehydration or even shock as we actually define it. So we should just be very cautious about fluid boluses, and sometimes a smaller bolus can be appropriate, like 10 mils per kilo, and then we reassess. But I think it's a good rule that any child who needs to have 10 and 10 mils per kilo of fluid as a bolus, if they need to be reviewed by someone senior, because they might need a different sort of response beside just more and more fluid. They might need an inotrope or a vasoconstrictor, or they might need blood, or they might need oxygen or adrenaline or something else. The point is that they need what's called a differentiated response, not just keep giving more fluid and more fluid and more fluid, because that can cause problems of get fluid on the lungs or cerebral edema, but particularly pulmonary edema and edema of the kidneys and other organs can occur. It's important if we see a child who has shock that we should not just think that the child's got bacterial sepsis, but there can be other causes of shock. And I've just listed some of these. I'll talk about this in another lecture, I think, because today we're just talking mostly about fluid and rehydration and electrolytes. But when we see a child with shock, we've got to think, is it a bacterial infection or a viral infection or something else like malaria? Or is it a cardiac shock? Or is it anaphylaxis? Or is it poisoning? Or is it some other unusual cause of shock like Kawasaki disease or some metabolic problem or some toxin like a toxin or a bite that can cause shock? So I think when we see a child with shock, we should be, of course, you can give a small fluid bolus and reassess and get someone senior to see the patient and reassess the patient together. But you also should think, well, what else could be causing this child's shock? So just in summary of today's talk, I know it's been a long one, but we just, when we're calculating fluids in dehydration, we need to know the maintenance and the deficit and the ongoing losses, and we add them together. When we worked out the standard treatment book fluid replacement, that's how it's worked out. The maintenance fluid for a given age and a given weight and the good degree of dehydration, the deficit and the ongoing losses. And so the tables in the standard treatment book really reflect that. But I thought it was important that you understand how the maintenance, the deficit and the ongoing losses are calculated, so we can be experts in the rehydration of patients. We should use isotonic fluids, the isotonic meaning like Hartmann's solution, not like 4.3% dextrose and 1/5 normal saline. We should avoid overhydration, so we use and teach the 4-2-1 rule, but we should start with 2/3 or 1/2 of maintenance fluid. We should know the TFI for all our patients. I think the total fluid intake for all our patients. We shouldn't give boluses of fluid to children who have febrile illnesses if they're not in shock or they're not hypovolemic. And sometimes if we are going to give boluses because patients are in shock, then I give 10 mils per kilo and then I reassess the patients. And if a patient's needing more boluses of fluid, then they should really have a review by someone more senior who's skilled in intensive care who can look at the patient. Or we should admit the patient to a high dependency area for close monitoring, if you like. And we should ask every day, does this child still need this IV today? And are we giving enough nutrition? So when you think about fluid and electrolyte problems in children, I think we've got to think about all of those things. All right, that's all I really wanted to say today. I'm going to stop sharing and turn off the recording, and then we can have some questions if you have any. So that's all for today.